honored to have Dr. Ephrat Levy Lahad with us. She's an expert in cancer, and it's a privilege to have her experience, and that's why I am going to present what we are working on currently, for her to understand what are our strengths and weaknesses and needs. So this is a project that started with Rina Gittler, who is also a very important person for our lab. So let me just start. This is the title of the project. It aims to identify germline pathogenic alleles in an extended panel of genes that predispose to cancer in Mexican patients with inherited breast and ovarian cancer. You know, I will be very short with this slide. Breast cancer is very important in all the world, in Mexico too. So we have a 20% incidence among all the different cancers in Mexico, and the mortality is 14%. Around 10% of our cases are inherited. That means that they are caused by a mutation that is passed through the generations. And among these mutations, around half of them are in the BRCA1 and BRCA2 genes. So now we are focusing on studying what are the other genetic components of this disease. To define this disease needs only one of the two copies mutated. So for every gene we have two copies, and if we have a mutation in one of those genes, this disease will manifest in the person. However, all the people that have a mutation doesn't present the disease, so that is incomplete penetrance. So, as Dr. Ephrat yesterday mentioned, there are many factors that affect the presentation of the disease. So having the mutation is not a sentence for the patient to have the disease. Mutations in the BRCA1 and 2 genes confer a very high risk for breast and ovarian cancer. And the patients that have these mutations generally are present the disease in very young ages, and their diseases produce a lot of metastatic lesions. They have a high risk of recurrence. The disease is present in both breasts in many cases, and they have also other types of tumors that occur at the same time. So clinically, these tumors are characterized by being the majority of them of this phenotype, which is negative for estrogen receptors and HER2 overexpression. So this is the most difficult cancer to treat because there are no specific therapies. So all these patients undergo chemotherapy, which is highly toxic, of course. So we did a humble but important work before. We studied this disease in 40 patients who would have hereditary, their families have a history of hereditary cancer. So we selected those 40 people, those 40 women at the NCI of Mexico, and we tested their blood by technology that is not currently available. It's obsolete now, but at that time was the technology, the most advanced technology. So that technology, in fact, allowed us to sequence 8 patients per month. It was a very tedious work and it was very complicated. So now we have better machines, which is very nice. So we found 10% of patients with a mutation in BRCA1 and 2. Those were the only genes that we studied at the time. And just to give you an example, this is the pedigree of one patient with cancer, this woman. So as you can see, the squares are the men and the circles are the women. So in this family, you can see these black circles represent women with cancer, and the lanes mean that the patient has died. So as you can see, we have here in the family 6 women with cancer. So we tested this woman. She had her diagnosis at 39 years old with a bilateral cancer, and then we detected this mutation, a BRCA2 mutation, which is a deletion of 4 nucleotides, so that affects the gene. And then we tested for that mutation the other members of the family. So we found that there were 10 asymptomatic carriers which didn't have cancer at the moment. So that is the main message that we want to bring to the people that we are working with in the public sector. So we can be effective in the prevention of this disease by identifying the carriers. So this was transformed or implemented in an institutional program at the NCI of Mexico. Now, that was the first program in the public sector in Latin America, and this is the number of families that have benefited from this program. So this was a very successful work, even though it was a small work with 40 people, but the impact, the social impact was very good. So, just to give you a little bit of background, we are not the first one to study BRCA mutations in the Mexican population. There are other studies. Here are just, you can see a summary of them. The most important ones. This is the one that we performed that I just showed you. There are other different studies that included patients just with cancer, and as you can see, these are the one in the center. Patients with cancer have this frequency of mutations without being selected for a family history of cancer. So these mutations are important also if you do not select the patients.
So they basically say that about 4% of Mexican breast cancer patients have the deletion, the exon 9 to 12 deletion. I see, and then the Villarreal is just for. And what's the difference there? Is it because there it's even higher?
Yes, this the Weitzel paper was focused on patients that were negative for sequencing of the gene. Mm-hmm. So they were looking for large deletions or rearrangements, and they found that this is the number of patients out of one of this number with the same deletion, and they did haplotype reconstruction, and they saw that there was a common ancestor.
Is it Mexican Caucasian or Mexican native?
Mexican native.
Native.
Yeah.
And so because I think the smaller, the Villarreal paper, which is smaller, has 96. Yeah. So there they write 29%. That's like sounds a little high, right?
Yes, it's true. It's true for not being a selected group of patients. But that's what they found. You can see, for example.
Yeah, but the triple negative, it makes sense that it would be even higher.
Yes.
Right?
Well, this mutation has a very high frequency. There is. You will see. We also detected this mutation in our cohort, and 30% of the patients, mostly with BRCA1 mutations, have this mutation. So it is a very important mutation. But this is what we already know. So now we are focusing on studying a broader set of genes to identify all the patients that do not have a BRCA mutations but have a strong family history for breast cancer and other cancers, which would make them prone to have other mutation in other genes, mutations in other genes. So as you can see here in this chart, the frequency of a mutation is has an inverse effect in the risk. So the most common mutations or alleles, I have to say, have a strong impact in the risk, but the rare mutations are the ones that have the higher risk. So there is also another group of genes which are immediate risk that have more frequencies, higher allelic frequencies, but they confer less risk. So essentially that's what we want to know and understand in our population. So for this, our main objective was to detect pathogenic alleles in an expanded panel of 143 genes in this number of patients that are selected by NCCN criteria. So this is our design. So this took almost 3 years to be accomplished. So this is the number of patients. We have a participation of 5 states of Mexico. These are the institutions that are working with us, starting with Alma, which I have to thank all the time that I give this presentation, because otherwise we couldn't be able to promote this protocol in all these hospitals. Then we used the standard criteria for the NCCN. Those were the ones that at the moment were the newest. And we have 2 groups. A group with breast cancer, so these are women that have been diagnosed with breast cancer. And also we have another group of people which have historical family history for breast cancer. So these are the 2 groups. Now the workflow was the same, with the difference that we used a better sequencing technology, and all the mutations that we detected were validated by the clinical valid Sanger sequencing. So this is an overview of the panel. This was done by Rosie. Where's Rosie? So she did this figure just to show that these 143 genes, it's a very good panel for us, because we can study essentially all these different cancer diseases that are inherited. So this is the number of amplicons, which is a large number of amplicons, and this is the over more than 500,000 of bases are covered by this panel. So we have an stringent variant filtering workflow. We use everything that is being published to now, so we reduce our from the mutations that we detect, we need to eliminate those that are not important. So we follow this algorithm. First, we eliminate technical errors that come from the sequencing machine or from the algorithms that we use to map the reads to the genes. Then we annotate everything that is inside the coding sequence of the gene and in the splice sites, and everything that is there, it's compared against reference databases that have the variation, the genetic variation of the general population. So everything that is found in the general population above this frequency, it's eliminated, because probably it is not going to be pathogenic. And this is a well-established number in the literature, a cutoff that many people is using in the literature. So then,
it's relatively stringent, though, right?
Yes, because we want to capture really what it is, pathogenic. So then we keep all of these variants that affect the gene. So there we have 3 examples here, variants that make a stop codon, so the gene encodes a protein that is truncated, so it's not a full protein and it's not functional, or if there are changes that modify the reading frame of the gene, which is also a pathogenic variant, and misses genes that are relevant and have been detected before as being pathogenic. So those are very easy to detect because they have been annotated before, or we can detect them very easily, and those are deemed as pathogenic. However, there are other missense variants that are annotated in these databases that we use, and we trust in these databases. Well, we trust what we verified, the data, of course. And if we see that the data is convincing, these missense variants are also classified as pathogenic. And everything that is here, we use these algorithms to identify changes that may affect the protein, the coded protein. But if there is not enough evidence, experimental evidence or patient evidence of its pathogenicity, we classify them as variants of unknown clinical significance. So these variants then are classified by the classification of the American College of Medical Genetics, which is a standard reference to classify the different types of variants that a patient can present. So we follow these international guidelines. Then let me show you the results. Here what you have is the deletion detected by Beitzel in 2007. So this is the locus of the BRCA1 gene, starting from exon 8 to exon 13. I don't have my glasses. And what Beitzel detected is this deletion. So essentially, we made our own version of the primers, and we detected the deletion by PCR. So we have two fragments here. This fragment, this is a small fragment that amplifies the gene that doesn't have the deletion. So this is the red line. The red dotted line is the deletion. And this fragment allows us to identify the correct allele. And this primer, along with this primer, only amplifies the deleted allele. So in this sense, by PCR we can detect the two alleles. So here, in this gel, you can see the control. So you have this larger band, which is this one, and you have here the deletion, here amplified. So we detected this deletion in 5 out of the 327 patients. So it's a fairly frequent deletion. Then we, I say we, but Rossi did all this work. We confirmed this deletion by Sanger sequencing, and we could detect the breakpoint between the two regions here in the locus.
But you have enough, I'm just trying to think. I was going to actually ask you if you do any CNV analysis or not.
Yes, she's doing
I'm
that.
sorry, I misunderstood that. Yes, we can detect it with the CNV.
Right, because you can look at the levels of other exons.
Yes.
And, okay.
We actually detected 4 out of 5 of these.
With the
Before doing this, I already knew that there were 4.
Based on the relative coverage
yes.
of exons.
Yes,
Okay.
yes, yes.
That's cool.
Yes, then we understood that we need to go above 100x of coverage to really detect this drop of.
Yeah, I mean that's the. Yeah, if you want to do CNV you should do CNV analysis, and I mean that's always more difficult.
Yeah,
But do you have what?
We're implementing it.
Yeah.
We detected it with a 60x mean coverage. We didn't need to go up to 100. We detected that, and right now I just confirmed that with 80x, it's like the right amount to detect it.
Do this PCR and to know if it.
Yeah, we talked about it yesterday. If it's 4% of your patients,
Yeah.
it's worth just starting out with that, and then you don't have to even NGS.
And it's cheap.
Oh, it's very cheap. This is like two pesos.
Yeah.
More or less.
I would say 2 shekel, but I'm in Mexico, so.
Probably faster.
What?
Probably faster than doing the whole library trial.
No, of course, no. Yeah, you flush them out of the system, right?
We could do it by PCR, real-time PCR, which would be like 40 minutes test. This is the distribution of the first group of patients, the distribution of the mutations that we found. So this is the number of patients which already were diagnosed with breast cancer. So as you can see here in this chart, the main genes in terms of frequency were BRCA1 and 2, that we already know are the main genes with mutations. But we found a very long tail of genes that have mutations, at least for some of them in 2 patients here. So what is striking here or interesting is that
and this includes the Mexican deletion?
Yes, yes, it is included here. It's coded in red.
Okay.
So you can see we have 5 patients with the Mexican deletion.
Okay.
And all the patients have only 1 mutation, which was also interesting for us. But you can see that there is a large number of genes that are affected in these patients. So this was one of the main outcomes that we have. You can see also that here we depicted the age of the patients. And as I mentioned in the introduction, these are young patients at diagnosis, so our mean age was 42, but we have patients that are under their 30s. Mm-hmm. So that's what I was very interested in, what you mentioned yesterday, because we have some of them that are very young.
But TP53 is on your panel probably, right?
Yes. Yes, but we didn't
find any.
This study also in the Jewish population, because as you know, well, you are expert, I don't have to say anything about this. This is important for us, so we want to start a project by studying in different phases the mutations that are present in the Jewish population. And,
can you just explain in a few words for Sharon why it's important, the Ashkenazi community? In a few words.
The Ashkenazi community is a fairly closed community. I'm afraid to say this before Ephrat Levy, because she's the expert in the field. But the genes, the genetic composition of the Jewish community is not as diverse as in other populations. So that means that the mutations are accumulated over time. And the frequency of pathogenic mutations that confer risk to many diseases or manifest in the disease itself is high. So we want to make a descriptive study to determine which are the mutations present in the community, because no one has done that. There is a lot of focus in other diseases in Mexico, but no one has focused in the Jewish community. But primarily we focus the study on women that are over 18 years old.
185-LAG is common in Iraqi Jews, so Jews who are found in Iraq, and Ashkenazi Jews who are Jews from Europe. And the last time, no problem. And the last time Jews from Europe and Jews from Iraq lived together was in Palestine, what is now Israel, before the destruction of the first temple, because when the first temple was destroyed, Jews were sent, were expelled to Mesopotamia, which is now Iraq. It could also be that some charismatic merchant from Iraq had fun in Europe, and that's how the mutation got there. So the dates are not that exact. But so if we're talking about 185-LAG, that's probably it's more than 2,000 years old. But the dating is not not that accurate. But I'm saying like 5382 insert C is a much younger mutation because that was introduced from the European non-Jewish population into the Jewish population.
I did not know that. The reason I'm asking is, is it expected to be the same risk of carrying the mutation in the Ashkenazi population in the different communities around the world?
So far it's been true. So if you look, I think the big groups that have been studied so far are in North America and in Israel, and they have very similar rates. We have maybe a little less of the Russian mutation, but it's nothing significant. So I would expect when you do it in Mexico, you're going to find the same thing. But like Felipe said, nobody knows because it hasn't been done. So
what could we expect in terms of the genetic component of Mexico? As you saw, we have our own issues.
So yes, I was going to say a couple of things. First of all, you've done a great job. I mean, it's really, I know it's not simple to collect so many patients and to do all of this analysis. So really, I'm really impressed. I think it's great. I think you face the same issues that we all face, and that is. First of all, I also congratulate you on thinking about moving this into the clinical arena, so offering testing to people who can't afford it. But that means you really have to start thinking about the next stage, which is not your responsibility, but somebody has to figure out, and that is you're going to give these results, what are people going to do with them? And I'm mainly concerned about all of your other genes, because I am not at all, I'll put it this way. Let's say you tested, you did an exome in these people, right? You would find variants in all kinds of genes, and you're going to be in a situation where you say, well, because I found this variant in a breast cancer patient, I have now decided that this is related to her breast cancer. And in fact, it may be completely unrelated. So I think you have to think about, I don't have a solution for you, but I think you have to think about which genes you're going to report back to patients. I can tell you, I think the people who are most advanced in this are the Australians. I don't know how familiar you are. There's Ian Campbell.
I saw them at the Vancouver, the ACH, the American Society of Human Genetics Congress.
Yeah, but also I think they have, you can send me an email if you don't find it. There was a recent BRCA symposium. I can send you the password for the presentations. So Ian Campbell in Australia is doing a huge study where they are taking unselected women with breast cancer. Their main advantage is that they also have controls. So they can, everything they find in breast cancer patients, they can look in the controls and see if the frequency is different. And they also have criteria for reporting back. So even though they do panels, they are so far reporting back to patients only BRCA1, BRCA2, CHEK2, and ATM. I think those are the only 4 genes that they report back, and the rest they don't report at all. And now I will say that if you find mutations in Lynch genes, you should probably report them back, but not necessarily in the context of breast cancer, but just saying we had this incidental finding. But, things like NBN, RAD50, ATR, I'm not even sure they're breast cancer genes, and I worry about, I think the work you're doing is really important, and you should continue testing it, but I think you're going to have to think carefully about what you report back. And like I said, these are things we all struggle with. A couple of things in terms of the analysis, I think what can give extra value, and we're trying to do that, and it's sometimes difficult, is to do some more phenotypic analysis. And what I mean by that is, you had there like an SHDB mutation. That's a pheochromosome, the succinate hydrogenases. I can never say these words, but anyway. Those are sort of paraganglioma, pheochromocytoma, or your MLH1 with colon cancer. So when you find something like that, I would go back to the family and to the patient and try to figure out if they have, you might find out that this patient with breast cancer has a family history that's diagnostic of Lynch syndrome, and you nailed it. You know why? So maybe her breast cancer is unrelated, but you know why she has an MLH1 mutation. So some of the genes where you actually have other or cancer syndromes with other cancers, I would go back to the families, try to figure out if they have it, or a patient like this. Let's say you can't get back to her family, but you can say do a colonoscopy. If you find she has your MLH1, so if you find she has polyps, again that gives you confirmation. If her colonoscopy is normal, the other thing is analyzing tumors, looking for loss of heterozygosity. I don't know if but I'm sure you can do that because it's you have all the molecular.
We have thought carefully about what you mentioned. Mm-hmm. We want to report back only the genes that are high risk.
Yeah.
And perhaps some of the medium risk that you said.
Mm-hmm.
But not all.
No, but I'm saying even for the variants you're not sure about, or the genes you're not sure about, I think there's further analysis you can do if you have access to the patient and if you have access to the tumor. I don't know how easy that is, but it's just a suggestion.
What about testing the families which we're going to find the high risk mutations? Do we have to screen them right away, or we can wait?
I think if you find a pathological mutation and you're reporting it back to the patient, then offering testing to the family should be done at the same time. They may not come, they may not want it. It's. But I think you really have to. You absolutely have to offer it. Yeah. And it's actually very simple, right? Because you're doing just mutation testing. You already did your Sanger. You already have, you know what I mean?
Yeah, we have all.
Yeah, it's testing the relatives is really easy.
With the hospital there, because it's not easy to get access to the family members. So.
Yeah, no, I think that's. I think what you're going to find is, you've done this great thing. You have everything set up, and now the clinical connection is going to be really important to you, both in terms of getting, achieving your goal, which is providing this technology to people, but it comes in a clinical context.
But as you see yesterday in the Hospital General, they don't have anything. So we're starting from the beginning that we have to create these genetic departments with genetic counseling that we don't have.
I would go. I would suggest. So I would suggest. And thanks for taking me yesterday. It gave me a sort of more of an idea. I think you have to find your own route and not necessarily go through genetics. And that's what I sort of said yesterday when you asked me after the talk. Go through the oncologists. Okay, if you, I'm sure oncologists are allowed to give back. Well, I don't know. You have to tell me. In Israel, we have a genetics law, and what the law says is that you can give results if you're a genetic results, either if you're a geneticist or if it's results within your area of expertise. So for example, in Israel, an oncologist can give back results of genetic testing that was done for hereditary cancer. I don't know what the situation in Mexico is.
There's no law, nobody knows, everybody does whatever they think they have.
That's okay, I don't like our law that much. So I would say, no, I'm serious, I think it has all kinds of issues. But unfortunately, we have a law, so once you have a law, you're sort of supposed to keep it. But here, if you don't have a law, so you're actually, in a simpler situation. At least for going through the breast cancer patients, go do it through the oncologist. The oncologist you give the result back to the oncologist. If it's a clearly pathogenic result, the oncologist knows what to do with it. If the oncologist doesn't know what to do with it, maybe set up a system of maybe a geneticist or two who knows something about cancer genetics, so that you have use NCCN guidelines.
Tomorrow in the UNAM, I will introduce you to my friend, which is an oncologist. She's going to give a talk tomorrow. Janine Chavarro, you know her? Janine, she works in town, and she's giving a talk. So it will be very important tomorrow. We can talk with her. She's one of my best friends. She's an oncologist, and she can work with us.
So I think do have them give the results, have them refer for the family members. And then I think and also there'll be a good connection for you if you want to go back to the family, if you want to, to get tumor samples, if you want to know more about family history. My experience has been that, patients are not that connected to their geneticist, right? They see a geneticist once or twice and that's it. But they are very connected to their oncologist if they have cancer, because they have to keep coming back and whatever. And so I think that's actually a really good clinical, as long as you're doing things in affected people, I would work with the oncologist.
I have a question. Will the oncologist here in Mexico will understand the genetic?
We're working on that.
Yeah, but
It's
No,
not
but I
that
think
simple.
for no, but I
They
think
know.
for
we will talk with Janine.
no, but I think for things like BRCA1, BRCA2,
sure.
people know
Well,
about
she's an
that.
oncologist that works mainly with breast cancer, so she's really related to it.
I also noticed that, you'll correct me if I'm wrong, but I understand that a lot of physicians work both in the public and the private sector. So I'm sure that those that are also in the private sector have had to have been exposed to this, because it changes treatment now today. You can't not, I was looking yesterday because I got the ASCO is going on right now, the American Society of Clinical Oncology meeting. That's a big oncology meeting. So I keep getting in my email like the news from ASCO. Half the news is BRCA1 patients need to be getting this as neoadjuvant. So if you're an oncologist in practice here, I don't see how you're, at least also in private practice, you're on top of this. I can't believe that they don't.
But the interpretation has to be clear.
You have to write, I was going to say, you have to write a very clear result. But that's true anyway, right?
So let's invite Janine to the team.
And the other thing is, the other thing you might think about is not reporting VUSs. But that's up to you.
We don't do that.
Yeah. So for example, the Australians also, they don't report VUS. They don't report genes they're not sure about. So it makes for a sensible system where I think you're going to be very useful to patients and to physicians, and so I think that's really good. Are you doing any analysis of splicing or?
Yes, we detected some splicing variants, and right now some of my colleagues are working on the.
So which tools are you using any splice prediction tools? Or not really?
Yes, we were using. I don't know the tools that we were using.
Where's Cristal?
She's not here. She's esperando las muestras.
Waiting something.
But yeah, we were using some.
Yes, we use different prediction tools, and we are cloning the exons.
Yeah.
And
you just do like mini genes, yeah.
We are also
because I guess one thing, that's the hard way. You can't get RNA samples from the patients.
We are willing to extract the RNA from the whole blood and to amplify the primers.
Because what we do is we use Tempest. We use Tempest tubes. You know those? Those are because you can't. Anyway, it's hard, especially with the shipping and everything, to get fresh blood for RNA. But there are special tubes called Tempest tubes, TEMPUS.
What is that?
They're Tempest. I don't know who makes. I can see who makes them. But the cool thing about them is once you draw the blood, you have to shake it a couple of times, and it's extremely stable at room temperature.
Oh,
so
can you give me the name of that? Maybe we have it.
Tempest tubes. It's just a general.
Buy them.
Yeah, you can buy
We are
them.
not using them.
No. So I'm telling you, that's what we use for.
I don't know those tubes.
Hmm?
I don't know those tubes.
No, because they're not normally Tempest tubes.
We have been using the ones.
It's Thermo Fisher.
Thermo Fisher.
Yes, it's called Tempest,
This
TEMPUS.
is the one used in the field when they go to some research and they are extracting sample.
So for DNA, right? Normally we take purple tops like EDTA tubes. I don't know.
That's
maybe
what
you
the ones
use,
we're using.
yeah, because in the States they like ACD for some reason, but we use EDTA tubes. But when we know that it's a sample, it's going to be hard for us to get back again. So we also take blood in a Tempest tube. It's stable at room temperature, and then once we get it, we freeze it. And then if we ever want to do RNA, then take it out of the freezer and make your RNA and cDNA, and then you can have it. It's just simpler than doing mini genes. What else
One
can
question.
I say? The other thing is I wanted to tell you there's another database you can use. It's from Mary Claire's lab. If you go into color genomics, just write Flossies, FLOSSIES. It stands for Fabulous Ladies Over 70 or something like that. Seriously, seriously.
Yeah, probably not golf.
What?
You know what golf is?
What?
Golf. The game golf.
Yes.
Gentlemen only, ladies forbidden.
Oh.
I think the empathy.
So what this is Mary Claire dot, I think it's from the Women's Health Study, but I'm not sure. She got, there's like 5,000 women there who are over 70 and don't have cancer. So if you find something really frequent there, you know that it's probably not pathogenic, and it's helpful for the VUSs. So yeah, you just write it, go in, you write your variant, and they tell you what frequency they have. So it's like a nice control. It's a nice control group.
¿Tú sabías? Exacto.
No, no.
Here I can. Here I'll WhatsApp it to Rina. The other thing is that the ACMG now endorses a prediction tool called Revel, R-E-V-E-L. And what's nice about that tool is that they already did the predictions for all possible missenses in the genome. So you can download chromosome segments, and for every nucleotide, basically for every nucleotide, they have all the options or all the possible codon changes, and they already predicted pathogenicity. So
Really like system polyphen, coding the non-coding regions also?
no, Revel is also just coding and just missense. But sometimes it's helpful when SIFT and polyphen don't tell you the same thing, which we all know is not fun. Okay, I'll send it later. I'm trying to play with my phone and talk at the same time. Yeah, so these were just the things I thought about. I think the rare genes are going to be a real problem because really you need a really large series to tell you if they mean something or they don't. So that's where I think the tumor analysis, phenotyping, that might be.
That's going to be very hard, the tumor analysis in the public sector.
Okay, so I mean, these are what I'm telling you about now is icing on the cake. Okay, it's the cherry on top.
We can do that.
The cake, you already have the cake. Okay, you have the big piece, the big thing in place.
Let's say like the
cake
is already in the oven.
What?
Let's say it's already in the oven.
No, yeah, exactly. So what I'm saying now is like a lot of sort of extras.
Okay.
But you can develop them as you go along. It shouldn't keep you from starting because I think you can. I mean, and certainly for BRCA1. And listen, the bottom line is the main genes are still BRCA1. Unfortunately, BRCA1, BRCA2. There was just this BRCA meeting in Montreal. Got me depressed. I'm thinking like, we've had these BRCA1, BRCA2 for 22 years, and it's we haven't really advanced that much since. Okay, maybe there's Check2, ITM, but nothing big since. So so I think that you're covering extremely well. So and the rest of them, you'll gather information as you go along. So it's great. Or you have some kind of database where you, sort of keep all of the variants you see.
We're working on that. We want to do an LOBD for all the patients with Lahad.
What we found also helpful is that our bioinformatics guy, what we have him do is, so every time we analyze a new set, in the final Excel, we have a column that says how many times have we seen this before? Have we seen it in affected? Have we seen it in healthy? Because that's very.
We're working on that.
Okay, that's a helpful piece of information. It's also helpful because sometimes there's just idiosyncrasies of your machine. Like there's just certain variants that are just come up because for reasons that are unclear. But,
I want to ask you something.
Sure.
We are, for the public project, we just want to report what it's valid, clinical valid, useful.
And those ones that have clinical guidance, no?
Absolutely.
Yeah.
We are interested in the other genes just for research purposes.
Right.
We also started a project which also involves the use of controls. So we now have a case control study because everyone is telling us the same. What do you know about the genes? Nothing.
Yeah, I know.
Nothing.
I know.
And the frequency in your own population, nothing.
It's very
Well,
important.
there is
I can tell. Okay. Yeah.
Exact has 55,000 more
South Americans?
Mexicans. The majority are Mexicans. So we use that to filter out.
That's where they say Latinos.
Yes,
I see. Yeah.
But most are Mexicans across the border.
Mm-hmm. Yeah, I understand.
So we are very careful controlling these high frequency variants that may seem to be pathogenic. But
I think I'll put it this way. I think it's an okay surrogate, but I think nothing replaces having your own
exactly,
your own
absolutely,
controls.
absolutely.
I think that's really important.
In terms of analysis, because there are different types of analysis, one of them is the polygenic risk score. What is your take on that? Because you have very rare variants spread across the genes. How can we measure their impact? We have a large cohort who will reach more or less 1,000 of controls and 1,000 of patients.
I don't know what to tell you about the polygenic risk score. I wish I had an answer. I'm not sure I believe it, and I don't. It's very hard to. I can't say I was convinced, and I would say, although Myriad has come out with, now when you send to Myriad, if they don't find a pathogenic mutation in the BRCA1, if they don't find a pathogenic mutation in one of the genes, they give you the polygenic risk score. Everybody has their own polygenic risk score. So, like the Europeans, they have. I have to remember now the name of the trial. Bridges. They have a huge trial called Bridges. You can look it up online. They're trying to do basically SNP scores on thousands and thousands of patients and controls. And even they haven't said that it's right for clinical use. So, and among them, now in the trial they're going to have their own set of SNPs. But the set of SNPs in the polygenic risk score also keeps changing. There's like a 60 SNP set, a 70 SNP set. I don't know. I think the thing to do probably is, collect all your cases and collect all your controls, and when you think you have a nice number, just, do whatever at the time seems to be the best one, and see if it's applicable in your population. That's all I can say. I think
I know you will get mad what I'm going to say, but Weissel has already many things about this, no? Weissel? What's that?
Yeah.
He has learned a huge range of Mexicans, so we can share some.
No, well, with Jeffrey Weitzel, you can share.
That's what I told you. Yeah, I said you can tell me that.
He's at the NIH? Or?
No, he's in City of Hope. When I was in Guatemala, I said, we want to establish this project with you, blah, blah, blah. But before we had this guy, Weitzel, he came here, did his study, he took everything, he gave no results. We don't want to work with people like that.
I'm telling you because Janine,
Argentina,
the oncologist,
same.
she has worked with him, so maybe through her we can get some values information that can help.
I think here the important thing is the numbers. So if you
The
have
numbers.
large numbers, we believe we can get around 3,000 samples from the LACAM project.
That's
so
great.
that's a fair number.
So I would say wait. What I would say with that is, collect your samples when you have a nice number of cases and controls. Controls here are going to be very important.
Controls.
Controls shouldn't be that difficult for you to get, probably.
They are more difficult than the samples.
No, I don't think so.
Oh yeah, but I have, how many controls do we have already? 400? So
We're gonna get it.
we have a good advance in that.
You have to get relatively old controls.
We have age pair controls.
Oh, great. That's the best.
And by side, we have.
Oh, wow, that's
this
really
is
great.
not done by us, it's done by one of our collaborators.
I see.
She's
So
an
that's.
epidemiologist.
Oh, okay.
She's
So
perfect. at
you're
that.
okay. So you're in
I
great.
don't do that.
Yeah. So you're in great hands. Okay. So I would just collect them and then then do the array on all of them at once and see if it if you do find a risk profile. I think that would be really important for and publishable, either if it's positive or if it's negative. It's really important. But I think right now it's really being mostly used to stratify in terms of follow-up. So I think I don't think you need it right now.
Well, we will have access to the tumors with Minero, in the IMS, and in the ISEMI also.
That I think is very, very important, because then you can do things LOH. Not only that, once you have a bunch of people with mutations in the same gene, you can look to see if their pathology is similar in terms of hormonal receptors, HER2, because you, at least in principle, you expect that if the biology is the same, then maybe the pathology, also will have similar features. Just like they figured out that BRCA1 carriers have more triple negative. So you could do that once you have numbers that are a little bit bigger. I think it's great. The other thing you can also think about is, if you have more of those extremely high risk families, to actually collect everybody you can find and do their genome.
I compliments to you, but we would like to have your opinion about our manuscripts and our scientific work. So
I'd be more than happy to.
what we would ask kindly from you is that you could revise our manuscripts, for example. If it's not that too much to ask. Final manuscript just to submit, like a final check, a front check. Okay. Good.
No, I'd be happy to take a look.
Obviously, you will be part of the offers.
No, it's okay. You don't have to. Yeah, no, okay.
And that takes up your time because.
Let's start. Don't worry. You don't have to pay me yet. I'm
No.
just kidding. No, it's okay. No, I'm serious. Send it to me and we'll see. I'll be happy to help. You don't necessarily have to have me as an author.
Thank you very much. This is important for us because we want to develop this area in the region. Without the problem of politics, Rita knows very well that politics is a barrier, tremendous barrier. So we have.
One thing I will say though is, if you want me to take a look at it, actually send me your design. A finished paper, I can only do so much if the design was, So I think actually, where maybe I can be more helpful to you is in once you figure out your protocol, and I can say, maybe think about this or think about that.
We can begin if we can review the one from the Ashkenazi community.
Ashkenazim is easy.
Just take a look.
Yeah,
Because yesterday we talked, Felipe and I, and there were some things that we have to change. The age and many little things.
No problem.
We're about to begin. I want to begin in August.
There's no reason you shouldn't. You can start today.
The committee here, not here, all around the world, the Bioethics Committee is giving us a very hard time. We have changed it a couple of times and they are giving us a very hard time.
Really? That's weird.
Have you heard about Dr. Raquel Gerson? She's the most famous clinical oncologist in the Jewish community. And she's
here in Mexico.
like most of the Jewish patients get treated by her, like regresó. And she's at the committee. We submit the protocol to the ABC hospital. The Jewish women go to general